This conference will now be recorded.
Good morning, everyone. Today, the topic of discussion is hyperthyroidism. So, first, we'll see about, what's the difference between hyperthyroidism and thyrotoxicosis. Hyperthyroidism is a state which is the result of excessive thyroid gland function. That means the thyroid gland is overactive, and there is a problem in the functioning of the gland. Whereas thyrotoxicosis, it is a state of thyroid hormone excess. The thyroid hormone can be secreted either by the thyroid gland or by the we can there is it can be due to intake of excessive thyroid hormone from through pills, or it can be due to the production of excessive thyroid hormone from the ectopic thyroid tissue, or from the it can be a part of the paraneoplastic syndrome. So hyperthyroidism is always associated with thyrotoxicosis, but thyrotoxicosis can be present without hyperthyroidism. So that's the basic difference. So coming to the causes of thyrotoxicosis, first we'll see what are the all the causes that causes thyrotoxicosis, and we can divide it into based on the differences we have seen previously between hyperthyroidism and thyrotoxicosis. It can be divided into primary hyperthyroidism, secondary hyperthyroidism, and thyrotoxicosis without hyperthyroidism. Uh, So what is primary hyperthyroidism? So this is the basic, the hyperthyroidism is due to the defective functioning of the gland by which it produces excessive thyroid hormones. So the pathology is in the thyroid gland itself. Some of the examples, the most common cause of primary hyperthyroidism is the Graves' disease. It is an autoimmune disorder, and we'll be discussing it later. First, we'll cover everything of the hyperthyroidism causes and all. So first one is Graves' disease, and next one is toxic multinodular goiter and toxic adenoma. So these are some of the surgical causes of the hyperthyroidism. In this, we have to differentiate between non-toxic and toxic, because in non-toxic multinodular goiter or non-toxic adenoma, there is no the state of hyperthyroidism is not present. That means thyrotoxicosis is not present. So there will be no excessive thyroid hormone secretions. Just a multinodular goiter will be present without any functioning nodules, and if non-functioning thyroid adenoma will be present in non-toxic adenoma. In another example is stroma ovariae. This is the ovarian teratoma, which has a ectopic thyroid gland, and it can be due to the intake of drugs. The one of the most common cause of primary hyperthyroidism is if we take the excess of iodine, and this is called as Jod-Basedow effect, which means due to the excess iodine in the body, the excessive thyroid hormone will be produced. And lastly, metastasis. It can any metastasis from another gland, from another organ like lung carcinoma, bone carcinoma. When it causes metastasis in the thyroid gland, then also it causes primary hyperthyroidism. Other causes are secondary hyperthyroidism. So secondary hyperthyroidism is the thyroid gland itself is functioning normally. So there is no problem with the thyroid gland, but the the problem is in another other parts of the body. So so the basic mechanism of thyroid is the functioning of thyroid. There will be secretion of TSH from the pituitary gland. So when there is a secretion of TSH from the pituitary gland, it will stimulate the thyroid gland and causes the release of T3 and T4 hormones. And these T3 and T4 hormones, they will make a feed loop inhibition on the pituitary adenoma. So, and when there is an excess of T3 and T4, then it acts on the pituitary gland and causes the decrease in the TSH, which in turn this decreased TSH will cause decrease in the production of the T3 and T4 hormones. So this is a feedback loop, negative feedback. So this one. So when there is any abnormality, when there is a pituitary adenoma, which is hypersecreting the TSH hormone, then this excessive of TSH hormone causes this TSH causes the acts on the thyroid gland, and it will release the T3 and T4 hormones. So that is the cause of secondary hyperthyroidism. So there is no problem with the thyroid gland, but the problem is in the pituitary gland when it has a pituitary adenoma. Specifically, if it is TSH secreting, because thyroid gland secretes many other hormones like GnRH, growth hormone, somatostatin, vasopressin, etc. So any of the hormone can be hypersecreted. So specifically, if it is TSH secreting, then only we have secondary hyperthyroidism. Another example is gestational thyrotoxicosis. This comes under the secondary hyperthyroidism. And if we have a choriocarcinoma, then also it causes overactive secretion of the T3 and T4 hormones. So coming to the causes of thyrotoxicosis without hyperthyroidism. So we have already discussed that thyrotoxicosis can be present without any abnormal functioning of the thyroid gland, which is hyperthyroidism. So those causes are subacute thyroiditis, silent thyroiditis. These two are the inflammation of the thyroid gland. The point which I have to mention is that acute thyroiditis and chronic thyroiditis do not produce a state of thyrotoxicosis. They just come and go. But whereas subacute and silent thyroiditis, they have a stage of thyrotoxicosis. Actually the thyroid hormone, the thyroid gland is actually diseased in this, but the production of the thyroid hormones is not dysfunctioning. It is normal. So we just have a period of thyrotoxicosis without any abnormal functioning of the gland. So that what is the pathogenesis of subacute and silent thyroid. We'll discuss this later. And the next one example is thyrotoxicosis factitia. This is the condition in which, as we have already discussed, it is the ingestion of the thyroid hormones like levothyroxine. If there is excessive ingestion of the thyroid hormones from outside. So one we have to rule out in thyrotoxicosis is the thyrotoxicosis factitia. So if we have any thyroid destruction which is caused by immutant or radiation, immutant is a very important drug which causes fluctuations in the thyroid hormone functioning. So we have to keep in mind immutant is also an important question, immutant affecting the thyroid hormone synthesis, and we'll discuss it later. And radiation is also another cause. Okay, so first we have already established that thyrotoxicosis is a state of thyroid hormone excess. So when there is thyroid hormone excess in the body, we get a lot of signs and symptoms, because thyroid hormone is the hormone which regulates the basal metabolic rate in the body. So when due to the if it is low, the basal metabolic rate is also decreased. So all the functioning, all the functions of the body, or else the dynamics of the body will be shifted, and it will be decreased, because the rate is decreased. The rate at which the body spends the energy itself on itself, like for the maintenance of the body. So it will be decreased. So we have we'll have all the all the functions of the body, all the body processes will be slowed down. Whereas when the rate is increased because of the increased thyroid hormone, if there is increased basal metabolic rate, everything will be increased. Everything will be on an overdrive. The body will be in an overdrive. So it will cause. So one of the this is all from the Davidson. So you can find this table there. The symptoms include weight loss despite normal or increased appetite. So weight loss is not the only criteria. It should be associated with normal or increased appetite, because generally if we have weight loss, it will be concurrent with decreased appetite, because that's how it goes. We have decreased appetite and there will be weight loss. But in this, it is a paradox. You will have an increased appetite because the basal metabolic rate is increased. The body will be demanding more of the energy. It needs more energy, so it will be having increased appetite, but that energy is not sufficient to maintain the bodily functions. So all the fat stores, everything will be exhausted, leading to weight loss. So that's the theory. And there will be, due to the increased, so everything we can take it back to increased BMR, so which causes heat intolerance, because there will be increased production of heat in the body due to increased BMR. So the patient will not be able to tolerate hot water or any hot weather. They'll prefer to be in cold weather, and they'll have sweating, tremors due to increased nervous excitability. So one of the then the patient will have palpitations and dyspnea, irritability, emotional lability, so and fatigue, sweating, tremors. So the symptoms of thyrotoxicosis, we can divide it into, because the thyroid hormones affects two parts of the body. So two systems will be mainly affected: cardiovascular system and nervous system. So in the cardiovascular system, we'll have some symptoms, and in the nervous system, whether it be mainly on the nerves, it acts mainly on the nerves. That is, it increases the nervous excitability. So it causes irritability, emotional lability, tremor. So these are all the causes of nervous symptoms. Tremors are a very important symptom and a sign. Um, Whereas the cardiovascular manifestations are palpitations, dyspnea, sweating, these are. And coming to these are the more common signs. Like, these are the first symptoms and sign we hear from the patient and we see in the patient. Signs of weight loss, tremor, palmar erythema due to increased circulation, sinus tachycardia, lid retraction, and lid lag. Lid retraction and lid lag, we commonly think that it is a part of the Graves disease, because it has a triad of ophthalmopathy, thyrotoxicosis, and dermopathy. But uh, the difference between the thyrotoxicosis and Graves disease is, in every case of thyrotoxicosis, when the disease becomes severe, we have lid retraction and lid lag. So these are, it is common in any case of thyrotoxicosis when it becomes severe. But Graves disease have its own constellation of ophthalmic symptoms, which we'll discuss later. So any case of thyrotoxicosis, lid retraction and lid lag are present. Uh, and less common causes of thyrotoxicosis are osteoporosis, diarrhea due to increased stimulation of the GIT, steatorrhea because of the increased mobility of the intestine, the vitamins, minerals, and the fat, the nutrients are not reabsorbed. So that's the cause of diarrhea. Muscle weakness, pruritus, ankle swelling, alopecia. So, and in contrast to hypothyroidism, where we have menorrhagia, there will be amenorrhea and oligomenorrhea, infertility, and spontaneous abortions. So any case of first trimester abortions, we have to think of thyroid hormone dysfunction, whether it be hypothyroidism or hyperthyroidism, both get in the way of fertility. So we have to rule it out. Uh, and another other signs are goiter with bruit. So goiter with bruit is an important finding in Graves disease, because there will be increased vascularity in throughout the gland, and increased vascularity causes increased flow in the thyroid gland, which causes a bruit. Anyway, any organ which has increased vascularity causes bruit, like hepatic bruit. Um, um, bruit is synonymous with bruit is synonymous with um, like a palpable murmur. So it's a palpable murmur. Um, Another important sign of thyrotoxicosis is atrial fibrillation and heart failure. So coming to atrial fibrillation, one of the causes of atrial fibrillation is thyrotoxicosis. but the difference between the other causes of AF and thyrotoxicosis is this is an like a kind of a bit. Uh, the thyrotoxicosis causes AF, which and it does not produce any other symptoms like heart failure, no, any structural changes in the heart. So it is called as the lone atrial fibrillation, lone AF. So because it has only AF and without any other signs and symptom manifestations like uh, left atrial dilatation. So these findings are not present in AF because AF is generally caused by left atrial dilatation. Uh, it is called lone AF. And there will be systolic hypertension, increased pulse pressure. Whereas in the nervous system, we have hyperreflexia, ill-sustained clonus. Clonus will be present, as we have already discussed, that it is due to the hyperexcitability of the nerves, and proximal myopathy. So, thyroid function test interpretation is very important in our OPD. So, because this is the first test we do if we suspect any thyroid dysfunction in the patient. So, it just has three values: TSH, free T4, free T3. Based on these three values, we can diagnose all these conditions which are present on the right side. So when everything is normal, TSH free, T4 free, T3, there is no abnormality. But these green, all the greens are highlighted except this one. These are relevant to our hyperthyroidism. We'll discuss about hypothyroidism also in like very briefly. If the TSH is low and there is increase in free T3 and T4, so it obviously causes hyperthyroidism, like we know, because that's the feedback loop. As there is increased secretion of free T3 and T4 by the thyroid gland, there will be feedback inhibition to the pituitary gland, which causes a decrease in the TSH. So it will tell the thyroid the TSH will tell the thyroid gland to stop secreting. So that's why the TSH will be low. Whereas the free T4, the thyroid gland will not listen to the pituitary gland and TSH. It has become autonomous. I'll just produce on my own. So it secretes increased free T4 and T3. It causes hyperthyroidism. Whereas the free T3 and T4 are still normal, but the TSH is low. That means the TSH is able to control the production of the free T3 and free T4. That means the thyroid gland has not become autonomous. It's still listening to the TSH hormone and the pituitary gland. So, uh, 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 first there will be increased T3 and T4, which causes the decreased production of TSH through the feedback loop. So this decreased TSH is able to control the thyroid gland, and it causes subclinical hyperthyroidism. That means we can detect it is in the early stages of hyperthyroidism, and we can detect if we can detect this earlier, we can rule out we can diagnose the cause, we can treat the patient, like we can rule out what's the cause and everything. So we can remove the causative factor if we are lucky to diagnose here. Whereas if it is sometimes rarely, like in less than 5% of the patients, the T4 will be normal, but the T3 will be high. This condition is called as T3 toxicosis. That means the yeah. Whereas if the only T4 is high and T3 is normal with TSH in the low, it is caused by thyroiditis, T4 ingestion, like the levothyroxine we prescribe to the hypothyroidism patients. This is also called as thyrotoxicosis factitia, and it is also seen in hyperthyroidism in the elderly or with comorbid illness. Another main cause of hyperthyroidism is TSH producing pituitary adenoma. As we have discussed earlier, as the abnormality is in the pituitary gland, it is producing excessive TSH, and this TSH is causing production of excessive T3 and T4. So, whereas the reverse condition, same the we will reverse this condition, and then it is the central hypothyroidism where TSH will be low, T3 will be low, and T4 will be low. everything will be low, because here also there is a the defect in the pituitary gland, but in this there is hyposecretion of the TSH, and it is also seen in euthyroid 6 syndrome. This is seen in critically ill patients like in ICU, sepsis, where the thyroid gland functioning will be decreased, and it will be actually the thyroid gland itself is normal, but since there is the patient is in sepsis and many other inflammatory markers, inflammatory um, hormones and everything will be present. So that causes the decreased secretion of TSH, free T3 and free T4. So that's that. Um, the most common condition we see in our OPD is the primary hypothyroidism. So in this, the reverse of hyperthyroidism, the TSH will be high and T3 and T4 will be low. And in subclinical hypothyroidism, there will be reverse of subclinical hyperthyroidism. The TSH will be high and T3 and T4 will be low. So coming to the evaluation, so we have so we are suspecting the patient with thyrotoxicosis. So as usual, as we have discussed previously, we'll mainly see TSH and T4 first. If it is TSH is low and T4 is high, we suspect primary thyrotoxicosis. And if the TSH is low and T4 is normal, then we measure T3. As we have discussed, some cases we have in T3 toxicosis, the T3 will be high and T4 is normal. But if it is normal, then we think of subclinical hyperthyroidism and we just follow up the patient. We have discussed this TSH is normal and increased T4, TSH secreting pituitary adenoma, or there is a rare condition called as thyroid hormone resistance syndrome. If everything is normal, there is no further test. So we'll get to the primary thyrotoxicosis. In this, first we have to rule out Graves' disease. Any patient with if we suspect a patient with thyrotoxicosis and if we confirm it is thyrotoxicosis, we have to first rule out Graves' disease because it is one of the most common cause of thyrotoxicosis. What are the features of Graves' disease? We'll discuss it later. If they are present, then it is Graves' disease. We'll conduct the tests further for it and we'll examine the patient further and we will rule out. If there are no features of thyroid Graves' disease, then it can be multinodular goiter or toxic adenoma. We can easily see we can easily diagnose it with palpation, ultrasound. And if we confirm it as toxic nodular hyperthyroidism, we treat it. No, but we have no evidence of goiter or toxic adenoma. Then we do a radionuclide uptake scan, technetium scan. So I'll discuss it later in the next slide. If it is if there is a low uptake, then we can then it is destructive thyroiditis or iodine excess or excess thyroid hormone, like outside ingestion of excess thyroid hormone. But if there is if there is a high uptake or if the thyroid gland is uptaking the radionuclide, we should rule out other causes including stimulation by chorionic gonadotropin, which is caused by choriocarcinoma. So this is another slide. I'll just skip to the thyroid scintigraphy. So when there is low uptake thyrotoxicosis, so the thyroid gland is not uptaking, like it is the thyroid gland itself is normal. There is no abnormal hypersecretion. We have discussed it. There is thyrotoxicosis without hyperthyroidism. So this is the transient thyroiditis or the subacute or the silent thyroiditis or due to the extra thyroidal T4 source. So there is no blackened areas in the scan. We just everything is homogeneous and white. Whereas if we see a nodule, if we see a blob of dark spot, then it is toxic adenoma. Whereas if there are multiple spots, like multiple blobs of darkness, like here it is one, here like everything is not uniform. It is very like we can identify different spots. So that is toxic multinodular goiter. But if the uptake is uniform, uh, everything is homogeneous, then it is Graves' disease, because these two have active spots, hot spots, which uptake the radionuclide scan, because the thyroid secretion is present only in these areas, whereas in Graves' disease, overall the gland is hyperactive, which is causing the disease. So that's the difference between toxic goiter and Graves' disease. So coming to Graves, it is an autoimmune thyroid disease, and it is mainly seen in females in the age group of 20 to 50 years, and this is the common age group for every autoimmune disorder. Um, and the Graves disease is diagnosed mainly, it is clinically diagnosed and biochemically diagnosed, not by yeah, and we confirm it by the radionuclide scan. So the clinical diagnosis of Graves disease is thyrotoxicosis, ophthalmopathy, dermopathy. So thyrotoxicosis is the main feature. Ophthalmopathy is the second main, and dermopathy we see it very rarely, but it is always associated with ophthalmopathy and thyrotoxicosis. So the mechanism of Graves' disease is not very clearly understood, but uh, after doing some studies, it is seen due to high iodine intake. So this causes the dysfunction of the thyroid gland, and it causes Graves' disease. It is a hypothesis, not a known cause. Coming to pathophysiology, since it is an autoimmune disorder, in autoimmune disorders there is the production of antibodies against our own thyroid cells, own cells. So in this also the antibodies are produced, IgG antibodies against TSH receptor on follicular cell of the thyroid gland. So these antibodies, uh, these are called the TRAB, thyroid hormone receptor antibodies. They attack the TSH receptor on the thyroid cell and causes destruction, which causes so the TSH hormone is unable to act on the gland and tell it to like decrease the feedback loop is gone now. So the gland has become autonomous and it will start producing T3 and T4 because of the destruction of the TSH receptor. There is no place for the TSH hormone to act on the gland. And it causes increased proliferation of cells and also the increased production of thyroid hormone, which in turn leads to goiter. And we have already discussed all the thyrotoxicosis symptoms. This causes features of thyrotoxicosis. Like we have discussed the signs and symptoms, how we diagnose it, and everything. Coming to the Graves' ophthalmopathy, this is the second most important feature in Graves' disease, and it is due to the overactivity of the sympathetic system, and it causes there is sympathetic activation of the levator palpebrae superioris muscle in the eyelid, which causes lid retraction or lid lag. It it does not lead to it does not it inhibits like the the eyelid is unable to close the eyeball completely. So that is lid retraction or lid lag, which in turn causes proptosis. One of the initial features of the Graves' ophthalmopathy are grittiness in the eye discomfort, and easily tearing of the eye. Um, and there will be because the lid is unable to close the eyeball properly. Sometimes there will be damage to the cornea due to the proptosis. And there will be development of the periorbital edema, scleral injection, chemosis. There will be diplopia because the eye is unable to turn because due to the periorbital edema. It will be hindering the eye movements, and eventually it will lead to it will compress the optic nerve and causes papilledema, and there will also be visual defects, and it will eventually leads to loss of vision. So what's the pathogenesis? In this, the pathogenesis for the ophthalmopathy, like thyroid and eye are nowhere related. So why does a thyroid gland dysfunction disease causes effects on the eye. It is because the cytokine mediated proliferation of fibroblasts which secrete hydrophilic glycosaminoglycans. So there are similar receptors on the eye cells, like which causes the TSH receptor TRAB antibodies to bind to the eye to the tissues on the eye. So these again these causes cytokine mediated proliferation. The fibroblasts will be deposited in the eye muscles and everything, and these secrete hydrophilic glycosaminoglycans. These glycosamino, since they're hydrophilic, so they attract water. So these increases the interstitial fluid content. The tissue fluid content will be increased, and this causes swelling and later fibrosis of the extraocular muscles. There is a scoring system. This is no need to memorize this. This is just to show you the progression of the symptoms. It's a no specs, so no specs scoring system. For the N, there are no signs or symptoms. There is in the eye manifestations have not started. Whereas later, only signs, no symptoms. The patient is not able to appreciate the symptoms, but if the patient presents at that stage, we are able to see. Later, there will be soft tissue involvement causing periorbital edema. Later, proptosis. P. E for extraocular muscle involvement. It's extending from ocular to extraocular. Later, corneal involvement as the proptosis has become the lid retraction has become more severe, and eventually leading to sight loss. That means the optic nerve is involved. So this is the picture in which you can see lid retraction. So the eyelids are very wide, and the patient will be unable to close it properly, and there will be periorbital edema. So this is the periorbital edema. There is conjunctival injection, the red marking here, and proptosis. The eyeball is pushed. Proptosis means the eyeball is pushed outwards. So that is proptosis. Okay. Next, the third feature is thyroid dermopathy. The main features in thyroid dermopathy are pretibial mixed edema and thyroid acropathy. So pretibial mixed edema, it is due to it is a indurated non-inflammatory swelling of the anterior and lateral aspects of the legs. So it causes an orange peel-like appearance on the legs. It is a non-painful, but it causes some problems. So this is the classical example for thyroid pretibial mixed edema. It can occur in any location, but as it is most prominent in the tibia area, it has got its pretibial name. Another condition, skin related, dermatological related, is thyroid acropathy, which is similar to the clubbing of the fingers, and it causes so yeah, this is the clubbing. It causes similar to clubbing. It also causes arthropathy. So these are the two manifestations. And thyroid acropathy is very rare. It's in less than 1% of the patients. Coming to the treatment, so the basic principle for the treatment of thyrotoxicosis is a beta blocker. It controls, since we have already discussed that it causes overactivation of the sympathetic and adrenergic nervous system, we have to prescribe a beta blocker, a thionamide. It is the antithyroid drugs. These are the antithyroid drugs. It causes blockage of new hormone synthesis. Iodine solution to block the release of thyroid hormone. We use it sometimes. It is a bit of an old medicine. And iodinated radio contrast agent to inhibit the peripheral conversion of T4 to T3. So these are the basic principles of treatment. In this, the antithyroid drugs, propylthiouracil, it is given initially in the dose of 400 to 600 mg, like daily, and we can use propylthiouracil or carbimazole 40 to 60 mg daily. So the main difference between these two drugs are propylthiouracil can be used in patients with pregnancy and postpartum, whereas carbimazole is contraindicated in pregnancy because it causes aplasia cutis in the fetus newborn. The one of the main feature, you have to remember, if you prescribe carbimazole or propylthiouracil, you have to watch out for granulocytosis. This is a very dangerous condition. The patient just presents with fever, throat pain, like acute pharyngitis symptoms, but it is a very dangerous condition. Uh, so there will be like there will be decrease in the WBCs, and the patient becomes very vulnerable. So we to other infections. So we have to like stop using the drugs if there is any granulocytosis. We have to always monitor the WBC. Another mode of treatment is subtotal thyroidectomy, or you can do near total thyroidectomy. Anything is fine. That's up to the surgeon. And radioactive iodine. It acts within 4 to 12 weeks. So within the uh, like between these 4 to 12 weeks, before it acts, we can use propylthiouracil or carbimazole and propanolol to like it destroys the thyroid gland. So that's the basic mechanism. The indications are you can use it in patients above 40 years, and if we have done surgery but it's still recurring, then you can use radioactive iodine to completely destroy it. And if the patient is having any comorbidity and is not suitable for surgery, you can use this mode of treatment, but this strictly contraindicated in pregnancy and breastfeeding. Another cause of thyrotoxicosis is subacute thyroiditis. Um, Subacute thyroiditis, it is also called as dequervian thyroiditis. So it is the transient inflammation of thyroid gland occurring after any viral illness like mumps, Coxsackie, adenovirus. So you will have a viral illness, and like 4 to 6 weeks, the patient will be normal, and later there will be inflammation of the thyroid gland. So that is subacute thyroiditis. It is the main features are a throat pain. It resembles acute pharyngitis. Like the pain is in the throat, which is radiating to the jaw and the mastoid, and there will painful. The patient is unable to chew. Normally we think that it is an acute pharyngitis, but the differentiating feature is the presence of a small tender goiter. um, and there will be neck pain. There will be painful and enlarged thyroid, and fever will be present. So there are three phases in the subacute thyroiditis. One is the first phase is the phase of hyperthyroidism. So this hyperthyroidism is caused by the accumulated thyroid hormones in the gland. Uh, these there will be these excessive hormones cause hyperthyroidism, and after they are all after the thyroid hormones get used up, there will be a phase of hypothyroidism. After that, the functioning of the gland will return to normal, and there will be a recovery. So this is the clinical course. First, it will be in its state of thyrotoxicosis. Um, Later, so in the thyrotoxicosis, the TSH will be, so this is the TSH, it is suppressed. We already know that in thyrotoxicosis there is suppressed TSH hormone, so it will be there. Afterwards, in 6 weeks time, the patient will it will be in a stage of hypothyroid, and then TSH will slowly rise. And the thyroid hormone levels will gradually decrease. This is the unfractionated period. So in the thyrotoxic state, it is increased, and then it become gradually decreasing. During the recovery phase, both will come to normal. So the basic mechanism, there is a thyroid follicular injury. So after it gets resolved, then everything will come back to normal. One of the most important phase, or the differentiating feature between thyroiditis and other forms of thyrotoxicosis is increased ESR. So this is the main difference we have to remember. This is the only thing. We treat it with aspirin for the pain, corticosteroids for the inflammation, beta blockers in the stage of hyperthyroid. There is no role of antithyroid drugs because nothing is wrong with the thyroid gland functioning. There is just inflammation. That's it. Silent thyroiditis, it is similar, everything is similar to subacute thyroiditis. In this, the patient does not have any symptoms of thyroiditis. They are just in a state of thyrotoxicosis. That's it. So there is no. It is due to inflammation of the thyroid gland, but the patient does not have any symptoms regarding the inflammation. That is, there is no pain, no fever, etc. The patient also has normal ESR, and there are presence of TPO antibodies. So these presence of the TPO antibodies are the cause of the inflammation, and there is a painless goiter. It generally occurs any patient with Graves' disease. Uh, they are at risk of going into silent thyroiditis, so we have to watch out for it. It is most common in the postpartum, and it is also called as postpartum thyroiditis. It is very common. Like if we have a patient with thyrotoxicosis, we have to watch out in the 3 to 6 months postpartum, because that is the period where the patient will be most vulnerable. So we have to watch out for in the postpartum. Any case of either thyrotoxicosis or hypothyroidism, we have to watch out for postpartum thyroiditis. This is also follows the same course as subacute thyroid, which is a thyrotoxicosis followed by hypothyroidism followed by resolution. And one of the important question for you is the Immutant-induced thyrotoxicosis. So Immutant is a type 3 anti-arrhythmic agent, which has a structure similar to T4. And it is used in the treatment of AF, which is caused by the thyrotoxicosis. So it is a complicated drug, and we use amiodarone in many of our arrhythmias. It is a universal antiarrhythmic agent. We can use it in any arrhythmia. So it is a very important drug, and we prescribe it in a very in many patients for the resolution of the AF. We give Immutant for almost every AF patient for the rhythm control. So it is a very important drug in cardiovascular disease, and many cardiovascular diseases are caused by the thyroid hormone dysfunction. So, and it also contains huge amount of iodine. We have already discussed the Jod-Basedow effect, in which the huge amount of iodine causes increased thyroid hormone secretion. So, amiodarone is like it is very con it is a controversial drug. Like, not that we should not use, but it causes a many number of problems which we have to watch out for in thyroid patients. So that it has a cytotoxic effect on thyroid follicular cells, first thing, and second, it inhibits the conversion of T4 to T3. So there will be excess T4 in the body. Oh, and there are two types of amiodarone-induced thyrotoxicosis. Actually, amiodarone causes three types of dysfunction. So the first is thyrotoxicosis. We'll be discussing it. Second is there will be suppression of the thyroid gland for a while. So that is one of the feature. And third is hypothyroidism. In some patients, it causes hypothyroidism for a prolonged period of time, whereas in some patients, it just causes a period of suppression for a few months. Later, it becomes normal. So we'll be discussing thyrotoxicosis since we are discussing hyperthyroidism. And there will be two types of amiodarone-induced thyrotoxicosis. Type 1. In type 1 patients, they have an underlying thyroid disorder. So they are already a patient of hyperthyroidism like Graves' disease or thyroiditis, etc. And we see a Jod-Basedow phenomenon, like because of the increased iodine in the amiodarone, it causes Jod-Basedow effect. Later in type 2, there is a type 2. In this, there is no intrinsic thyroid abnormality. The thyroid is absolutely fine, but it causes thyroiditis due to the cytotoxic effect we have discussed, leading to transient thyrotoxicosis, which will resolve. So this is the basic mechanism of amiodarone on the thyroid gland. Coming to treatment, for type 1, we just use antithyroid drugs, whereas for type 2, we use prednisone. Like, first we start with both. Whichever the patient responds, we'll withdraw the other. We also use potassium perchlorate, and but if the like if it is very severe, the thyrotoxicosis, and if it is not resolving, we go for near total thyroidectomy after controlling the thyroid hormones. We can also use lithium. So one of the dreaded most dreaded complication of the thyrotoxicosis is thyroid storm. Um, Thyroid storm, it also referred to as thyrotoxic crisis, is an acute life-threatening hypermetabolic state induced by excessive release of thyroid hormones in individuals with thyrotoxicosis. So when the increased hormones causes chaos in the body, suddenly it becomes acute conditions. Suppose there is surge of thyroid hormones in the body due to any cause, we'll discuss. It is life threatening, and the body goes already is in overdrive, and it goes haywire. Like everything goes haywire, and there is a hypermetabolic state, and it is the most extreme state of thyrotoxicosis. Whatever the signs and symptoms we have seen in thyrotoxicosis, it is on the, it is we'll see it in extremes. There will be heat tolerance and diaphoresis. Like it is common in thyrotoxicosis, but because the heat tolerance will manifest as hyperpyrexia in the thyroid storm. The temperature will go to like 106 degrees Fahrenheit, which is very dangerous. So these extreme high metabolism also increases oxygen and energy consumption. When the body is unable to provide it, it causes death. The precipitating factors are uh, in general causes like infection, trauma or surgery, psychosis, parturition, MI or other medical related conditions in a thyroid patient, already in a patient of thyrotoxicosis. When these happen, the patients go into thyroid storm, whereas the thyroid specific conditions are sometimes the side effect, it can be a side effect of administration of radioiodine or a high dose of iodine containing compounds, sudden discontinuation of the antithyroid drugs, thyroid injury, and new institution of immutant therapy. So we have already discussed it. Sometimes the patient can go into thyroid storm. The emergency treatment will be administration of propylthiouracil through IV, as it inhibits the conversion of T4 to T3. It is used acutely, like as an IV. First, we give a dose of 1000 mg, followed by 400 to 600 mg every 6 hours. Or if it is not available, we can also use methimazole. Later, stable iodine is used. Propanolol, beta blockers, it is as like short-acting IV drugs, beta blockers like esmolol are used, or propanolol can be used. The point is we have to, anything is IV since it is an emergency. Later, glucocorticoids and bile acid sequestrants are also used. So that's it. Any doubts? You can.